I'd like to start this morning discussing an overview of where we are with cardiovascular prevention. And I'd like to start, if I may, with this particular lesion. Now, you know, certainly this is a ruptured atherosclerotic plaque with an occluding thrombus. And it's the #1 cause of death for men and women across North America and around the world. And preventing this disease is what this conference is all about. So who's this fella? Everybody remembers Tim Russert, the noted NBC political news reporter. You know, felt fine, never had any symptoms to speak of. Had some metabolic issues, but clearly his LDL cholesterol was under 70, it was 68. He had a stress test a couple months previously, was perfectly normal. And one day, while sitting in the newsroom, he suddenly clutched his chest, developed crushing chest pain, fell down and dropped dead from a heart attack. And everybody was aghast. How could this happen? Well, this is residual risk. This is an example of what we're going to be discussing at this meeting. How can we do a better job of preventing this disease that snatches people in the prime of their life? And there are a lot of women here today, and certainly I know a lot of you have seen this slide, but clearly women, their biggest threat is cardiovascular disease. And this slide says it all. Here's women middle age at 45 years and older. The blue line represents death from heart attack. The yellow line is death from stroke. And it dwarfs all other causes, including breast cancer, colorectal cancer, and the like. So I think we're going to also focus at this meeting on women's health as it relates to cardiovascular disease prevention. We're delighted to have Dr. Rita Redberg, who will be discussing this on Saturday. Well, we're at the dawn of a new era in cardiovascular medicine and cardiovascular prevention. Our ability to build a shield around our patients and radically reduce their risk of having a cardiovascular event, an acute ischemic event, whether it be a heart attack or stroke, or peripheral vascular catastrophes. And what is this new order? Well, for one, we know that atherosclerosis is no longer considered to be simply a bland cholesterol storage disease. Kind of a plumbing analogy. We gradual buildup of sludge, and then you choke off the artery and you have a heart attack. Well, that's not really what happens. The root cause of atherosclerosis is the retention of atherogenic ApoB lipoproteins, followed by a maladaptive, and I may add, deranged inflammatory response. That the vast majority of these plaques that rupture and lead to acute events are not what we thought. They're not the 90% obstructive lesion that goes on to 100%. Most of them are small non-stenotic plaques, what the surgeons call soft buttery disease, these highly inflamed little plaques or pimples in the artery wall that suddenly rupture. So you can go from a 10 or 20% obstruction to 100% in a matter of seconds. And that's why a lot of the patients that we see with acute events had no prior symptoms. That cardiovascular intervention, although it's of critical importance and truly life-saving in the unstable patient who presents with an acute ischemic syndrome, has never been shown in the stable population to prolong life or prevent future heart attacks compared to medical therapy. And finally, and most importantly, that therapeutic lifestyle intervention and optimal medical therapy is the best approach to treat, to prevent, and indeed to reverse atherosclerosis. So I'm going to start with a review of, in order for us to set the stage for this meeting, let's talk about the vascular biology of atherosclerosis. So here we are, these are particles that carry cholesterol and triglycerides. You have particles that are potentially atherogenic, that are tagged with an ApoB lipoprotein, and 90% of these atherogenic lipoproteins are LDL particles. We have Lp(a), which is the most atherogenic of all the particles, and we have IDL, VLDL, chylomicron remnants. We say potentially atherogenic because they all are fully capable of entering the vascular wall and creating havoc, with the exception of the very largest VLDL chylomicron particles greater than 70 nanometers. And then we have HDL particles tagged with an ApoA1, and these are potentially protective. We say potentially because you can have dysfunctional HDL and proatherogenic HDL. I've also mentioned this maladaptive inflammatory response. Well, what's so maladaptive about it? Well, in order to answer that, let's talk about a normal inflammatory response. So let's take a bruise, okay? And you see in a bruise you have extravasation of red cell and red cell fragments in the vascular wall. In comes a macrophage and engulfs this debris, if you will, and then does something that all dendritic cells do. They leave. They go to regional lymph nodes to deposit their cargo. Well, the atherosclerotic plaque is different. It's different because we have these atherogenic ApoB-containing lipoproteins, and they enter a porous vascular wall. These endothelial cells really are not a barrier. We have an ebb and flow all day long of ApoB lipoproteins entering and leaving. And if there's too many of them, they bind to proteoglycans, get trapped, they get modified, and then our inflammatory foot soldiers are like sharks sensing blood. And they say something is wrong, and they attack these modified lipoproteins, and they become foam cells. But then something different happens. These inflammatory cells don't behave like dendritic cells. They stay. They don't leave. And not only do they stay, but they become the problem. They become the problem because they start releasing very important substances that lead to the further progression of the plaque, to the subsequent rupture of the plaque, and then to the thrombosis that occurs afterwards. So they release lipoprotein lipase that enhances further binding of the lipoproteins to the proteoglycans. They release proteinases that break down the fibrous cap of the plaque, decreasing the tensile strength and making it more likely that they'll rupture. And they release tissue factor, this intense procoagulant, which along with activated platelets, when that plaque ruptures, leads to an acute thrombus. Now, I love analogies, and one of my analogies here is a brick house. Because what do you need? If you wanted to build a brick house, what building material must you have? Otherwise, you're not going to get a brick house. Bricks. Not enough bricks, no brick house. Not enough ApoB lipoproteins, no atherosclerotic plaque. So we understand how important that is. And this was a study by Lamarche and colleagues, the Quebec Cardiovascular study, which looked at the too many lipoproteins. So here's an individual with too many small dense lipoproteins, LDL particles. And where do you find that? You find small dense particles in insulin resistance and metabolic syndrome and type 2 diabetes. And these particles, when they flow, we all took high school chemistry, from high concentration to low concentration within the vascular wall. So we get these particles crashing the artery wall, and eventually we get plaque buildup, as I just showed you. Now, if you think that large particles are therefore your friend, think again. Because large particles, if there are too many of them, can also get into the vascular wall and create havoc. And the phenotype of that is familial hypercholesterolemia, FH. So at the end of the day, what's important is not whether the particles are large or small, it's the particle number, the concentration of these particles. And if we have normal particle number or count, we don't increase the risk of cardiovascular events. And this is especially true when we have genetic polymorphisms that lead to increased particle number over a lifetime. We have a lifetime exposure of the vascular wall to atherogenic particles is where we see in the PCSK9 data and in the other genetic polymorphisms over a lifetime, we significantly increase risk. One thing that we're going to discuss this afternoon, and one thing seems obvious, but it gets confused and distorted, that LDL cholesterol is not LDL. Most times when people are talking about LDL, they're talking about, what they mean is LDL cholesterol. LDL is a lipoprotein. We can get discordance between LDL cholesterol and LDL particle number. Here's an example of that. So we have two patients. We have Sam and we have Max. They both have the same LDL cholesterol of 100. But Max over here, because he's got metabolic syndrome and he's knocking on the door for type 2 diabetes, has more particles. In fact, you can have up to 70% more particles with the same LDL cholesterol. Which, if you wonder why somebody like Tim Russert dropped dead, and in the New York Times the following day, everybody was aghast, or articles saying, you know, let's throw out the cholesterol hypotheses. No, we didn't understand discordance. Because when you have too many particles crashing that artery wall, of course you're going to be at higher risk. This is something that can be measured. You get an ApoB, you can get an LDLP, as we'll discuss. You can get non-HDL cholesterol, which is a better reflection of particle number than is LDL cholesterol. So at the end of the day, what we have is a vulnerable patient. And who's a vulnerable patient? A vulnerable patient is an individual with vulnerable blood, who has these metabolic derangements, like too many particles, atherogenic particles, that can lead to vulnerable plaques. And certainly, we as preventive physicians and healthcare providers, if we're going to convert vulnerable plaques to non-vulnerable plaques, unstable plaques to stable plaques, then our charge is to clean up the metabolic derangements that lead to vulnerable plaques with lifestyle intervention and medical therapy as needed. And that's really what we should be doing. So I know that, you know, over the past decade, we've had a number of studies that have looked at plaque regression. And really, that's the holy grail. Everybody says, my gosh, can you take my 90% blockage and convert it to a 0%, get rid of it? The asteroid trial, ApoA1 Milano data shows that you can get plaque regression. But to me, the most important thing is plaque stabilization, because that's an achievable clinical goal in all of our patients. We can stabilize these plaques all over the body, you know, in the brain, in the heart, and the periphery. And we, again, do that with what we're going to be discussing at this conference, lifestyle intervention along with medical therapy. So let's start off with looking at therapeutic lifestyle intervention. And this morning, we're delighted to have Dr. Vasanthi Malik, who's going to be discussing nutrition. And, you know, what is the optimal diet for cardiovascular health? Well, many feel that based on the sheer volume of clinical trial data showing that a Mediterranean diet is a diet that has evidence-based, and you'll hear that evidence this morning, might be the optimal diet. There are other diets that are also worthwhile. But I had the good fortune of participating in an International Atherosclerosis Society meeting a couple of years ago in Rome, Italy. And afterwards, my wife and I traveled to the Tuscany region of Italy, spend a week in a small little town that nobody's heard of. And in order to get something to eat, you had to get up in the early morning because there were no supermarkets there. And you had to walk. You couldn't drive because there was no highways leading to the outdoor markets. And you had to walk several miles through the vineyards and olive groves. And when you finally got there, there was a virtual cornucopia of fresh fruits and vegetables of all different colors, bringing all the antioxidants to the table. And of course, here's the cold water fish that brings omega-3 to the table, the red wine with the polyphenols and resveratrol. This is how we're going to beat cardiovascular disease, with a good pair of walking shoes and a knife and a fork. And you're going to be hearing that this morning, and I fully believe it. That's our first order of business and our first defense against cardiovascular disease. Now, modern man is genetically maladapted to his present environment, just like your automobile. Your gas-powered automobile is maladapted to diesel fuel. And if you put diesel fuel in your gas tank, your car will break down. Well, we're putting the wrong fuel in our gas tank. And that fuel is really the toxic American diet, which is highly processed, it's calorie dense, and it's nutrient depleted. And certainly we have to change that diet if we want to achieve good health. We cannot rely on the pharmaceutical industry alone to get us to the promised land, and we certainly can't rely solely on stents and bypass surgery. Again, they're of critical importance in those that present with acute ischemic syndromes, but the basis for all of this is lifestyle intervention. You're going to see a lot of data to follow. I'm not going to go over this because Dr. Malik will, but articles in JAMA showing the data. This was a huge study in the New England Journal of Medicine last year, actually in 2013. The part of the PREDIMED study looking at primary prevention of cardiovascular disease with a Mediterranean diet, which significantly reduced the morbidity and mortality of cardiovascular disease, those randomized to a Mediterranean diet. So the bar has been set. And an editorial in the New York Times the day following the New England Journal article stated that this is a watershed moment in the field of nutrition. For the first time, a diet has been shown to have an effect as powerful as drugs in preventing what really matters to patients: heart attacks, strokes, and death from cardiovascular disease. How about sugar? You know, we all know sugar is bad for us. Last year we had Robert Lustig, gave a wonderful presentation, but it's really the biochemistry of sugar, which is half glucose, half fructose, and fructose is a bad player. It goes directly to the liver. It can be converted, and it can lead to all manifestations of metabolic syndrome. It can be converted to uric acid. Uric acid inhibits nitric oxide, therefore leading to hypertension. It can go down to the mitochondria, the Krebs cycle, and the citrate shuttle and lead to de novo lipogenesis, pumping out fatty acids, which can spill over into the liver, leading to fatty liver, or it can be packaged into VLDL particles as triglyceride-rich VLDL, which can then lead to obesity. And free fatty acids can certainly, downstream products, diglycerides and ceramides are toxic to tissue, what we call lipotoxicity, and can lead to insulin resistance. That causes a state of hyperinsulinemia, which can inhibit leptin, which is our satiety hormone. We're walking around hungry all day. I could spend 3 hours on this, trust me. This is really what's driving our obesity epidemic, and it's certainly what's driving our epidemic of metabolic syndrome. Well, I could tell you missing in action is fiber. I love this topic. I gave a 1-hour lecture last month on the role that soluble and insoluble fiber plays in cardiovascular health. And it's of critical importance. I mean, this was a study that there's multiple studies to show benefit, up to 40% cardiovascular disease risk reduction consistently observed in those who consume fiber-rich, especially whole grains. It's interesting, the definition of processed food is fiberless food. Our food industry takes the fiber out. Food lasts longer on the shelf without fiber. But fiber is needed. It's needed to reduce inflammation, to lower lipids and lipoproteins, decrease oxidation, improve insulin sensitivity, weight control, and very importantly, its impact on gut flora. That's the new thing that is really a lot of Stanley Hazen and others at the Cleveland Clinic have written many articles on this. Decrease obesogenic gut flora. And again, we could talk about this for a long time, but the data is clear. Walter Willett coming out with a recent study showing that post-MI, those that consume more fiber do better, lower cardiovascular morbidity and mortality. All right, how about red meat? Should we abandon red meat? Not necessarily. Clearly the biggest problem with red meat is the fact that it's highly processed. It's processed with nitrates and nitrites and pesticides and antibiotics and steroid hormones. And certainly the data behind red meat, the largest study worldwide has by Rashmi Sinya and his colleagues at the NIH, 250,000 men, 250,000 women, randomized to 5 ounces of red meat once a day versus 5 ounces of red meat once a week. Those that consumed red meat once a week had a significant decrease in mortality, driven mainly by a reduction in cardiovascular mortality and a reduction in cancer mortality. And the data was even more striking with processed meats, salami, bologna, hot dogs, and the like. So the punchline is that certainly decrease the amount of red meat. If you're consuming too much, doesn't mean you cannot have red meat, a good steak if you like that, in moderation. And extrapolated to all Americans, these findings suggest that over the course of a decade, we could save 1.5 million lives just by eating less red meat and certainly try to avoid entirely processed meat. And one of the confusions that we had, because people that red meat, they think of saturated fat, and they say, oh, the data is totally incorrect, we dropped the football. And we did drop the football back when the American Heart Association declared war against fat, and fat was the enemy. So what did the food industry say? Okay, thank you very much. We'll just put refined carbohydrates in the food. And we were off to the races. Did we decrease cardiovascular events? Absolutely not. Because refined carbs and excess sugar, whether it's table sugar or high fructose corn syrup, is clearly as detrimental because a high sugar diet is a high fat diet. So we didn't understand that, and we dropped the ball. But what is truly important is what we replace the saturated fat and the trans fat with. If we replace it with unsaturated fat, we have evidence-based data that we decrease the risk of coronary heart disease. Exercise, I'm delighted to tell you that we've got Dr. Peter Kaczmarzyk, who literally has been on the cutting edge of the data surrounding exercise. This is interesting. This is a national meeting. Here's all our colleagues taking the escalator up, and these are the healthcare providers that are going to be carrying the torch, telling people how important it is to exercise. And it's pretty sad, isn't it? Although this guy's, I guess, taking the staircase. Well, sitting time, just sitting, is bad for your health. Prolonged sitting, which many Americans, as you know, 5, 6, 7 hours a day are sitting. And, Dr. Kaczmarzyk was one of the first to have an article talking about the relationship between those, dose-response relationship and association between sitting time and mortality from all diseases, including cardiovascular disease. Well, exercise in general we know is important. This is way back in the mid-1950s when Dr. Jeremy Morris noted that those who drive a double-decker bus in London had double the heart attack risk than the conductors on the bus running up and down all day long. In the United States, we did a study years ago showing that sedentary postal workers, clerical workers, had double the heart attack risk as those that delivered mail on foot. And this is a study from the Women's Health Initiative, Nurses Health Study, Women's Health Study. These 3 studies are huge. And they show that just walking 30 minutes a day, most days of the week, can cut cardiovascular risk by 30 to 50%. So at the end of the day, what we understand is that being unfit is a major risk factor. And really what we should try to do is get our patients, almost 90% of our people walking around the United States are unfit. And we should get them at least to be mild to moderately fit, because that's where we see the biggest bang for the buck as far as a decrease in mortality. Now, you could get more and more fit. I used to say that's wonderful. It's like statin therapy, you get less, it's the law of diminishing returns. Some recent articles suggest that super endurance athletes may not benefit at all from extreme forms of exercise, and we'll discuss that in the panel discussion. Well, how can fitness be so protective? A lot of it has to do with sick fat. Or there's a difference between adiposity and adiposopathy, which Dr. Harold Bays is going to discuss tomorrow. And it's very important because clearly with this flawed lifestyle, unhealthy diet and sedentary lifestyle, We increase substrate. We overwhelm our adipose, especially subcutaneous adipose tissue, and those adipocytes they swell up, they become hypertrophy, and they become dysfunctional. And as a result, we pour out free fatty acids, and they're looking for a home. So where do they go? There are visceral adipose stores, and they become metabolically active, pumping out all kinds of inflammatory cytokines, angiotensinogen. And then they start, the visceral adipose site becomes also insulin resistant, and when you have insulin resistance, you take the brake off of lipolysis. So you get mobilization of free fatty acids. And we have a condition called lipotoxicity, where these free fatty acids, end up in tissues like the pancreas, leading to diabetes, like the liver, leading to fatty liver, like the blood vessels and heart, leading to cardiovascular disease, and on and on. Stress is important. I wish I had a lot of time to discuss this, but I don't. But fortunately, we will be talking about stress today. We know that early man had the fight or flight response when confronted with a threat, poured out catecholamines. This got us ready for battle, so we could either flee the threat or fight the saber-toothed tiger. Well, modern man today has about 20 to 30 stressful episodes a day. And not only do we pour out catecholamines, but we pour out glucocorticoids. And that's why chronic stress is particularly dangerous, and it leads to cardiovascular events. And so, at the end of the day, what we really want is to have a balance between our sympathetic and our parasympathetic nervous system. You can think of the sympathetic as rest and relaxation, vagal tone. And if we tip the scales too far on the side of sympathetic tone, we increase cardiovascular risk. We've got Dr. Carl Fullwire, who will discuss mindfulness today, and that's really the new thing that's out there, the science of mindfulness to achieve health and well-being. Sleep apnea is another condition which will be discussed this afternoon. And if a patient has sleep apnea, that's important to note that, because it's directly related to cardiovascular disease through a number of different mechanisms. Also, a midday nap. Very important. The siesta is performed all over the world. A couple of years ago, we got this data out of Harvard, Antonio Tricopoulos and colleagues, who said that those who take a regular midday nap cut the risk of dying from a heart attack by 37%. That's as good as we get from statins. Now, today we live in a new world. We live in the 2013 ACC-AHA guideline. And, certainly, I think the new guidelines have done a lot of good things, raising awareness of those who should be on statins. But there has been controversy. And that's why this meeting is so important. It's to get all these things out in the open and to discuss in a collegial way different ideas as how we could build the best mousetrap as far as guidelines that we disseminate to be able to keep people out of the hospital and out of the cath lab. Here's the 4 statin benefit groups. I'm not going to go over this. You'll hear about that from Dr. Ann Goldberg, who is on the expert panel. Here's our new risk assessment pooled cohort guidelines with a chair Donald Lloyd Jones produced, which is different than before. We're now looking at not only calculating a risk for a heart attack, but also stroke. We're not only looking at Caucasians, but African Americans. So in some respects, it is very good. However, there are those who feel that we can improve risk by using inflammatory markers, lipoproteins, coronary calcium scores that you'll hear Dr. Nasir talk about, and the like. Tomorrow morning, I'm going to be discussing the results of the Improve It trial, which is a landmark trial showing for the first time the non-statin agent ezetimibe added to simvastatin having incremental benefit compared to statin monotherapy. And that's an important trial for a lot of reasons, because it directly impacts our new guidelines. Should we return to, now we have evidence that it's just not statins. We can't have just statin-centric guidelines now with this new data. So how do we incorporate that, and how do we modify the new guidelines, and should we start looking at targets of therapy, since that study showed a significant decrease in events at a lower LDL cholesterol. Now, who is this? Everybody know? Everybody been to the Louvre in Paris? Mona Lisa. And why am I showing you a picture of Mona Lisa? Because this is the first documented case of FH, which is FH is familial hypercholesterolemia. And it's the most common of all the genetic, metabolic, hereditary disorders. And this picture was painted, of course, by Leonardo da Vinci, who, interestingly, was a scientist interested in atherosclerosis and wrote several papers on atherosclerosis. So one wonders, did he take particular pains to make sure that this Mona Lisa's left eyelid, she was 24 years old when he started the painting, is what? It's a xanthelasma, linked with FH. Here's a subcutaneous lipoma on the dorsum of her right hand. She died suddenly in her mid-30s, which we believe now was probably from a heart attack. In any event, we'll be discussing FH, and most patients with FH have a defect in the LDL receptor. However, there are other mutations that you can have in the receptor adapter protein, and there are mutations in ApoB and mutations in PCSK9. Everybody know what that is? If you don't, trust me, you will. So here's PCSK9. So here is an LDL particle, and it lands on an LDL receptor on the liver, and it's internalized in clathrin-coated vesicles and taken to the endosome. And within the endosome, because of the acidic environment within the endosome, you get dissociation of the particle and the receptor. The receptor is then recycled to the cell surface, so it lives to see another day, so it can continue to be pulling atherogenic ApoB particles out of the circulation. And the particle itself that is taken to the endosome is then taken to the lysosome, where it's degraded into cholesterol, certainly fatty acids, and amino acids. Now, the liver can produce PCSK9, which is a protein that's produced in the liver in an inactive form. And it's then shuttled to the endoplasmic reticulum, where it is converted to its active form, and it's released back into the plasma. And in the circulation, now we have PCSK9 binding to an LDL receptor. So when the atherogenic particle comes along, the LDL particle, we now have a particle receptor PCSK9 complex, and they all end up being taken to the lysosome and all being degraded. So therefore, with the presence of PCSK9, we don't get recycling of the LDL receptor, and as a result, with fewer LDL receptors, LDL cholesterol goes up. Okay? Now, what was fascinating about this is some pivotal studies, especially Jonathan Cohen and Helen Hobbs, noted that with a loss of function mutation of PCSK9, there was a significant decrease in risk. And it was, the decrease in LDL cholesterol was mild to moderate, but the decrease in risk of almost 90% in African Americans of developing cardiovascular disease was significant. Why is that? Because you're decreasing exposure of atherogenic lipoproteins to the vascular wall over a lifetime. And so now we have agents that can inhibit with monoclonal antibodies PCSK9, and the studies are in progress. And you're going to be hearing more and more about PCSK9. Michael Davidson will discuss this, because this has the potential of being a true blockbuster. It's significant lowering of LDL cholesterol and particle number and Lp(a) beyond statin therapy. How about our new blood pressure guidelines? We have Suzanne Operol, who is the co-chair of our JNC8 guidelines. And I like to say just the JNC8 and our blood pressure guidelines was not without its own set of controversy, because there was one of the new changes in the guidelines is changing the target of treatment for those 60 years old and older from 140 systolic to 150 systolic. Well, there was committee members that said, wait a minute, we don't go along with this. If you do that, you raise the target to 150, you're going to increase cardiovascular morbidity and mortality, and it's mainly going to be driven by an increase in stroke risk. So they actually published on their own, 5 members of the committee, a minority position, arguing against doing that. So it'll be interesting to hear from Dr. Oprel, and right now, we're still torn. Do we treat our patients who are over 60 to the new 150 goal? Can we go to the 140 goal? And that'll be certainly discussed. Dr. Harold Bays will also be discussing smoldering insulin resistance, which I dare say majority of Americans are walking around with a degree of insulin resistance, just like they are with metabolic syndrome. And this is really putting them on a crash course with diabetes and cardiovascular disease. And certainly, we're also going to be looking at men's health. We have, this is a study by Dr. Kevin Billups, who looked at the topic of erectile dysfunction in men. And what he states is that the diagnosis of ED is a powerful clinical tool to improve early detection and initiate prompt, aggressive medical management. And this actually is going to be discussed by Dr. Michael Blaha at the meeting. Dr. Billups is going to discuss another interesting and somewhat controversial topic: testosterone, low testosterone, and cardiovascular health. And certainly this article that appeared in JAMA 2013 was a little bit controversial. The use of testosterone therapy was associated with increased risk of heart attack, ischemic stroke, and total mortality. So the FDA has weighed into this. They weighed into this past summer when they put a warning now on all testosterone products, stating that clearly that these products can cause venous thrombosis. And they're now looking into whether or not the testosterone products can increase the risk of stroke and heart attack. So I think, reading between the lines, and we're going to hear about this from Dr. Billups, but certainly those that truly have hypogonadism, low testosterone, despite all our efforts to change it with lifestyle intervention, exercise and the like, can actually raise testosterone levels. But it shouldn't be willy-nilly that every man out there should, can get testosterone products. And I think that we'll, I'm sure, have a lot of questions after that. Aspirin will also be discussed. What's the role of aspirin in cardiovascular disease prevention? My good friend and colleague, Charlie Hennekins at Harvard, did this study years ago, the Physicians' Health Study, where in healthy physicians, he noted a significant 44% reduction in the incidence of first myocardial infarction in those randomized to low-dose aspirin. That was great for men, middle-aged men, but we never knew the answer for women. All these years, women were saying, hey, how about us? Well, now we do, because this study performed by Dr. Ritger and Dr. Julie Bunning at Harvard, the Women's Health Study, noted that there was no decrease in first heart attack in women taking low-dose aspirin. There was a decrease in stroke by 19% in women aged 65 and older. So at the end of the day, if there's no contraindication to chronic aspirin therapy, and again, it's a risk-benefit ratio. You're not going to put anybody on aspirin who's got a bleeding ulcer or contraindications for it. If they have risk factors for heart disease with no contraindications, it is reasonable to consider the use of aspirin in men over the age of 45 to prevent first heart attack, women over the age of 65 to prevent stroke, or all men and women with prior history of cardiovascular disease. Now, one thing about aspirin, what about aspirin resistance? How do you know if you put a patient on 81 milligrams aspirin that you have enough aspirin on board? Well, there was a fascinating article that was published this past year on the use of urinary thromboxane levels to help guide us. And if we have, especially in high-risk individuals, where you want to make sure that you have enough aspirin on board to inhibit thromboxane, you can measure urinary thromboxane. And if it is inadequate, you could raise the dose or switch to other antiplatelet agents like clopidogrel, and that'll be discussed by Dr. Peter McCullough. One of the things that we'll also discuss is stroke prevention guidelines, which is very important. But really, one of the things I'm excited about is by introducing later in this meeting Dr. Italo Infante, who just got back from the International Stroke Conference, where they presented late-breaking clinical trials. These are all randomized controlled clinical trials which showed overwhelming superiority of endovascular stroke therapy compared to standard medical therapy with IV TPA for acute strokes. This is groundbreaking, and it's going to represent a paradigm shift in what we could do to help prevent morbidity and mortality from stroke. One of the studies suggests a 50% decrease in mortality in stroke if you get the patients to the lab early enough. And I think it's going to be a very, very interesting lecture, and this is hot off the press, so definitely stay tuned for that. So let's return to the scene of the crime. And so here we are back at the vascular wall. And we go to into the artery wall, where we see the plaque being put together with more and more lipoproteins. What's the future, and where are we headed? Well, clearly with lifestyle intervention, statin therapy, now with ezetimibe, maybe in the future PCSK9, we can decrease the number of lipoproteins that enter the vascular wall, and therefore decrease the likelihood that a plaque will become unstable and rupture. And also, by doing so, an aggressive decrease in lipoproteins within the plaque has been shown to lead to emigration of the inflammatory cells, the macrophages, out of the plaque, decreased proteinases, decreased tissue factor, and the like. So I'd like to close my talk today with a great quote from a Chinese medical text, Huangdi Naiqing. In the year 2600 BC, a Chinese doctor wrote this. And he stated that inferior doctors tend to treat the full-blown disease, whereas mediocre doctors treat the disease before it becomes evident, but superior doctors prevent the disease. I certainly would like to thank you for your attention, and I hope you enjoyed this year's symposium. Thank you very much.